masses. And you know that we have many imaging modalities to assess the pelvis, especially the ultrasound, the CT and MRI, and we may have the role of the plain X-ray to have some idea about what's going on in the pelvis, as I will show you. The CT scan of the pelvis is usually performed in the female cases after oral administration of contrast material to delineate the bowel loops, and also intravenous contrast material to enhance the vessels and to discriminate between masses. And this does two images showing how good the preparation of the patient by the orally administered contrast material. MRI, you know that we have four machines: the closed magnet, the open MRI, the extremity MRI, and the dynamic MRI, where you can examine the patient in the weight-bearing situation while she is standing. Then we use an MRI superficial or surface coils, and this is one of the coils that we use for imaging of the female pelvis. Then we have to state some of the facts before going into the lesions, how the signal appearance of the different structures in the pelvis. Actually, you know that we have the T1 and T2 within images, and if you are not a radiologist, you can know the T1 from the T2 by the signal of fluid. And the bladder is taken as an example, and you see the fluid in the T1 weighted images is black, while in the T2 weighted images is white. Then a cyst in the ovary containing fluid similar to that in the bladder will appear black in the T1 and bright in the T2 weighted images. And what are the structures or the lesions that appear black in both images, in the T1 and in the T2 weighted images? Number one, the cortex of the bone. Number two, mature fibrous tissue. And here we have the example of, let's say, ovarian fibroma and the fibroid present in the uterus. Then calcium. All these structures will appear black in the T1 and in the T2 weighted images. Then what will appear bright in the T1 and somewhat dark in the T2 weighted image is fat. Then if you look here, this is a cyst in the pelvis, and the cyst contains fluid. The fluid is dark in the T1 and bright in the T2 weighted images. But look here for this number 3, and there is a lesion which is bright in the T1 and bright in the T2. This lesion may represent fat or may represent blood. Then let's say dermoid cyst contains fat and the hemorrhagic cyst contains blood. How can you discriminate between both? Fat will be somewhat dark in the T2 weighted images, but blood will appear bright in both T1 and T2 weighted images. Then if you see a bright lesion in the T1, this may represent fat or may represent blood. Then you go to the T2 weighted images, or if it persists bright, then you know that this is hemorrhage. A second way is to do what's called fat suppression. You suppress the signal of the fat, and in spite of being bright, it will be dark. Then if this lesion contains fat, it will be suppressed, it will appear dark. If it contains blood, it will persist as a high signal. And this is an example of a dermoid cyst in the ovary. This is T1 weighted image, and this is T2, and this is T1 after fat suppression. You see the fat component, which is bright in the T1, will be suppressed in the T1 fat suppression. And look here, there is a cyst in the ovary which is bright in the T1 and also bright in the T2 weighted images, and after fat suppression, it persists as a bright lesion, and this is a hemorrhagic cyst. But look for this cyst which is bright in the T1 but less bright in the T2 weighted image, and this is an endometrioma, and this finding is known as the shading sign. A hemorrhage in the endometrioma will not persist of high signal in the T2 weighted image. It will show some somewhat decrease in its signal intensity in the T2 weighted images, and of course if you have this fat suppression, it will not be suppressed. Then we came to our topic about the ovarian tumors. We have the benign lesions and we have the malignant lesions. On the benign side, we have the dermoid, the serous and mucinous cyst adenomas, ovarian fibroma, and granule tumor. On the malignant side, we have the three major types: the epithelial carcinomas, germ cell tumors, and stromal carcinomas. This is the appearance of the normal ovary by ultrasound, and the normal ovary contains follicular cysts, and the cysts are usually of different sizes, and this is the regular or the normal size of the ovary, 3 to 5 centimeter in length, 1.5 to 3 centimeter in width, and 0.5 to 1.5 in thickness. This is the appearance of the ovaries on either side of the uterus by ultrasound, and this is the appearance of the CT of the ovaries. This is the left one, and this is the right one. And by MRI, especially in the T2 weighted image, you can see, you can identify the ovary by the presence of follicular cysts, which will appear of bright signal in the T2 weighted image. And the cyst in the ovary in the range of 2 to 3 centimeter in diameter is considered as a follicular cyst, and it will show clear water content and the hypoechoic appearance on the MRI, on the ultrasound, and hypodensity, homogeneous hypodensity on CT scan. And the cyst in the ovary may enlarge, may reach a large size like this, but it will maintain the typical criteria of a simple cyst anywhere in the body. And these are 3 positive findings and 4 negative findings. The simple cyst should have a sharply defined margin, paper thin wall, clear water contact. And there is no internal septation, no mural calcification, no contrast enhancement, and no soft tissue component. If you have a cyst anywhere in the body, in the kidney, in the liver, in the spleen, in the ovary, and this simple cyst, it should have these typical criteria. Then we came to the benign tumors, and we mentioned the teratoma, the serous and mucinous cyst adenoma. Teratoma, you know, it is a benign lesion, or also called the ovarian dermoid cyst, and the diagnosis is based on the detection of fat inside the lesion. And this is one of the values of the plain X-ray, and you can see some tooth-like calcification in the pelvis. Then you can diagnose this as an ovarian dermoid, of course, if this is a plain UT of a female patient. And this is used many times in the exams, as you know. But if you have the CT scan, you may see the 3 components of dermoid cyst: fat, calcium, and fluid or somewhat solid component. Then, if you see here, and you can see a cystic lesion, which is predominantly made of fat, and this is different from the fluid. The fat is more dark at the CT images, and inside the dermoid, you should see other soft tissue material, which represented the other types of tissue inside the lesion. By MRI, the dermoid cyst will appear bright in the T1 weighted image, less bright in the T2 weighted image. If you cannot appreciate the decrease of brightness in the T2 weighted images, then you go to the fat suppression. And this is the fat suppressed image, and you can see that the whole lesion is suppressed, meaning that it is containing fat. And by CT, you can see this is what's known as the dermoid plug, which is the solid component of the lesion. This is fluid, and you can see some septations, and this is the solid component, which is made of fat and calcium as well. And here, dermoid cyst can be bilateral, and this is an example of 2 dermoid cysts, one on the left and one on the right. And it's very important to see the fat. And many times you can see calcium and also the other soft tissue material. Then by MRI T1 weighted image, fat will appear bright. In the T2 weighted images, especially in higher strength magnet, you cannot appreciate the decrease of the signal in the T2. Then you go to the fat suppression, and you see that the whole component of the fat has been suppressed. And this is an example of dermoid cyst in the right ovary, showing typical appearance: fat, calcium, and some other soft tissue material. You know that the complications of the dermoid cyst are the same for any cyst everywhere in the body, including rupture and torsion or being secondary infected, for example. This is an example of a huge dermoid cyst in the ovary, and you see the fluid, and you see the fat, and you see the calcium as well. And the differential diagnosis of a dermoid cyst in the ovary, this is T1, this is T2, and this is T1 fat suppression, includes the hemorrhage. And hemorrhage may occur in the hemorrhagic ovarian cyst or ovarian endometrioma, and both contain high signal in T1, but they will show different appearance in the T2 and in the fat suppressed images. Most of other lesions containing fat in the ovary are extremely rare, like liposarcoma and immature teratoma. In cystadenoma, we have two types, the serous type and the mucinous type. The only difference between both is the serous type is usually a single cavity, while the mucinous type is a multilocular cavity with different contents of the different loculi. And this is one of the helpful criteria to separate both. And you can see this is serous cystadenoma, which is classically a single cavity, huge in the abdomen. It may reach this very, very big size. And inside this cyst, you cannot see calcification, you cannot see septations, you cannot see mural nodules, and sometimes it can be mistaken for a huge simple ovarian cyst. Then here is a serous cystadenoma of the ovary, and because of its size, it usually goes into the abdomen, as you can see in this case. Then the mucinous cystadenoma contains septations, and here you get an example. A huge cyst also, and you can see internal septations, but very importantly, you do not see solid component. Solid component means that you are dealing with a malignant pathology. But only here you can see cystic septations, and you may also see some calcium. And this is a good example of a mucinous cystadenoma, and you can see the septations and you don't see the mural nodules. One of the good ways to diagnose this mucinous cystadenoma is MRI, because MRI can differentiate between the signal of the different contents, and this is diagnostic. And this is MRI of the mucinous cystadenoma, and it's of low signal in the T1 weighted images and of bright signal in the T2 weighted images. And this is also an example. You see a big lesion containing internal septations and of bright signal in all T2 weighted images. In the ovarian fibroma, you know its relation with what's known as mixed syndrome, where you got ascites, pleural effusion, and solid ovarian tumor. I have said in the introduction that lesions that contain fibrous tissue will appear black in all bulk sequences in the T1 and T2 and all imaging technique. Then this is a T2 weighted image. You see the endometrium, which is bright in the T2. You see ascites, which is bright in the T2. And this is ovarian lesion, which is black in the T2 weighted image. And this is T1 and T2 and T1 fat suppression and T1 fat suppression with contrast. The tumor will enhance, but it will appear dark in the T1, in the T2, and of course in the T1 fat suppression. This is also an example. This is the ovarian fibroma on the left side. This is T2. The fluid in the bladder is bright, and after contrast enhancement, you can see faint contrast enhancement compared to the pre-contrast imaging. And this is a ovarian fibroma by CT, and it's a solid lesion which may contain calcium. On MRI, T2 weighted image, the endometrium is bright, the lesion will appear dark. Then the Brunner tumor is a relatively rare tumor, and the diagnosis is based on the detection of calcium within this lesion, which is frequently solid. And knowing that MRI is less sensitive for calcium detection, then the diagnosis by CT is good. And here you can see a solid lesion with a few calcific foci inside the lesion. Frequently, the Brunner tumor are associated with other serous and mucinous cystadenomas, and also may associated by cervical carcinoma, for example. This is the classic appearance of Brunner tumor by CT, solid lesion containing calcium, and by MRI, and you see the lesion of low signal, and in the T2 weighted image it shows very, very dark signal in the T2 weighted image, like air, for example, in the core. Then we came to the ovarian malignancies, and we have the epithelial tumors, the serous and the mucinous cystadenocarcinomas, endometrioid carcinoma, and the clear cell. Of course, we cannot discriminate between the cell types of the ovarian cancers, but we are able by imaging to say that this is carcinoma and this is a benign lesion, based on the detection of a solid component inside the lesion. You know, most of the ovarian tumors are solid, are cystic, and the detection of internal septations does not indicate you are dealing with a malignant lesion. But if you see a solid component, whatever is smaller the size of this component, then you should think of you are dealing with a malignancy. Then a cystic lesion with a solid component, a big cystic lesion with septations and the solid components, then you think that you are dealing with malignancy. And to confirm your diagnosis, if you can identify metastatic lymphadenopathy, peritoneal deposits, and ascites, they may help in the diagnosis. And here is a CT scan of the pelvis and knee. You can see a cystic lesion with a big solid component. Then you are dealing with a malignant lesion. And it's known in the literature that the serous cystadenocarcinoma usually occur in both ovaries, in bilateral disease. And you can see here you have two lesions in the both ovaries. Both lesions are cystic, but they contain solid components. And this is also now an example. Here you can see the ascites along the the lower edge of the liver, and you see the cystic mass with internal septations and solid components. And this is also an example of, you cannot say from imaging, this is an endometrioid carcinoma. And even by the pathology, it needs a very expert pathologist to say that this is an endometrioid carcinoma, but you have the malignant features from this CT scan. Of course, if you see that the lesion is containing fat and calcium, then you may say that this is teratoma, and because of the metastatic lesions along the edge of the liver, along the subphlegmatic area, along the peritoneal reflections, and you know that this is malignant teratoma. Ovarian metastases usually go to the peritoneum and they initiate the presence of ascites, and ascites is one of the helpful tools to detect the peritoneal deposits. And you know that the omental cake or the massive peritoneal metastasis will appear like this, a big soft tissue mass underneath the anterior abdominal wall, and then you see the presence of ascites as well. And this is an example of a huge omental cake, and you can see in the coronal image. And many times you can see the omental cake, but you cannot see the tumor because it is small. Then we used to biopsy this omental cake to know what's going on. Then the malignant germ cell tumors are the tumors of young age, and they are not frequently seen in adults, and there are many types, but most of them are extremely rare, except for this germinoma and somewhat the immature teratoma. These tumors are diagnosed by two main facts. Number one, the size. Number two, the age of the patient. If you see an adolescent and teenager has a very big ovarian mass, whatever it is, cystic or solid or both, and you think of this is germinoma. And the juvenile type is more common than the adult type. And this is a female, 19 years old, and you see a big mass in the pelvis with solid component and cystic component. And this is another example. You should remember the age of the patient is young and the tumor is big. And these are the two main criteria that you can help you to suspect the possibility of a germ cell tumor or germinoma. Like this one is very big lesion in the pelvis extending into the lower abdomen, and this is a female 12 years old with huge solid mass extending into the lower abdomen. And this is also a teratoma, and this immature teratoma with calcium and fat inside the tumor matrix. Ovarian lymphoma is usually of the secondary type, and primary ovarian lymphoma is extremely rare. in these patients, to diagnose ovarian lymphoma, you should see one of two. Either the patient is known to have lymphoma anywhere in the body, or you can see in the abdomen the typical appearance of lymph nodes of lymphoma, which are bulky, homogeneously enhancing, and do not contain calcium nor areas of breakdown. Then if you look here, and you can see there is a big mass in the pelvis, and this mass affects the ovaries, and in the retroperitoneal area you see the appearance of lymphomatous nodes, which are bulky, homogeneously enhancing, no internal areas of breakdown or calcification. You know that ovarian metastases are usually bilateral, and they are usually small, and they are usually solid. And these metastases frequently come from the stomach or the gastrointestinal tract, sometimes from the breast tumors, and they are known as the Krukenberg tumors. Solid lesion, unilateral or bilateral, in a patient known to have a primary malignancy is suggestive of a Krukenberg tumor. And in the exam, you can, in the study, you can see the tumor itself. And here you see a diffuse, significant gastric mural thickening and an ovarian lesion, which should represent a Krukenberg tumor. And this is MRI T1, T2, and T1 both contrast with fat suppression. You can see bilateral ovarian masses that are more or less solid. They enhance strongly after injection of contrast, diagnostic of Krukenberg tumor in a patient with gastric carcinoma. And this is also a Krukenberg tumor, bilateral solid masses in the ovaries. And this is a patient with cancer colon. You can see hemicolectomy, and you see a big mass. This is not usual for Krukenberg tumor, but the solid nature of the lesion, the presence of primary malignancy are diagnostic of Krukenberg tumor. And thank you.